My name is Inge Soons. I also work for NICTIS as a medical terminology advisor. I have a background as a medical doctor. And I was asked to demonstrate like a specific application which is provided by Snomed CT, which is called the data demonstrator or data health analytics. I will, well, Feike already told something about Snomed, but to be able to understand like the demo, I'm going to tell something briefly about the structure of Snomed. So you can read it, I think. So Snomed, we call it, is the language of the health professional that is also understood by computers, which means that every health professional can use their own terms. So a medical specialist would maybe use another term than a general practitioner or a patient. So they can use their own terminology in their documentation. But because one concept with multiple descriptions has one unique Snomed code, you can exchange medical information. So that's one of the main purposes of Snomed. And another purpose of it is reuse of data. And, well, one thing is to select cohorts, for example, for research. So to explain again, Feike already told, like Snomed concepts, they are defined by relationships. This differs from like a terminology like ICD-10 or ICD-11, in that ICD-10 says, okay, it's maybe a lung disease or it's lung cancer, and then you have all the types of lung cancer. In Snomed, it goes like in more levels. So you would have lung cancer, then you would say it's a malignant lung cancer, and then you have a subtype of that, and then a subtype of that, and a subtype of that. So it goes way further. So Snomed is called a reference terminology, and aggregation terminology is more like a classification system like ICD-10. So Snomed is one of the main terminologies we use for, well, it says eenheid van taal, but semantic unification. LOINC is used for like laboratory terminology, and IDMP for medication is a medication standard. So if you make it visible, this is what the structure of Snomed is. So the S, that means like a Snomed concept. And then some of the main categories are clinical findings, you can see it, procedures, objects, and body structures. So here you can see it goes further and further down, but also that one concept can fall into multiple trees, you would say, or hierarchies. So for example, like pneumonia, which Feike mentioned, by CMV, that could be either like an infectious lung disease, but also an infectious disease caused by CMV. So that's why you get the crisscross structure. So there are a lot of terms in Snomed CT, like around 300,000. So you may not want to use all the terms in your research or in your EPD. So it's also possible to select, like make subsets of these terms. So this is how a Snomed concept looks like. I used the example of a bacterial pneumonia. So this falls in the category of an infective pneumonia, but it's also a bacterial infection of the lower respiratory tract. On the right side, you see the attributes or the relationships. So you can see it's an infectious process. It's caused by a bacteria. The morphology is inflammation, consolidation, and the places or the location is the lung. And you can see that we call it parents and children. So the parents are the supertypes and the children the subtypes. So these relationships are really important and usable for like extracting cohorts from live data. So you could say I want all the patients with an infectious process in the lung caused by a bacteria, for example. So that is the demo that I want to show you. Oh, this is the end. So this is a tool developed by Snomed International. There are 1 million data in this. They're all simulated patient data. There's one particular use case developed for this. I have to say it's a demo, so it's not used yet, but it can show you like the possibilities of a terminology like Snomed CT. So say you would want, say you have a patient who has an autoimmune arthritis, which is an inflammation of a joint caused by like a reaction from the body itself. And you want to give it like a medication that suppresses the immune system, like a TNF blocker, which is a medication that does that. But the patient also has a chronic lung disease. And then you have a risk that if you suppress the immune system, that the patient may develop a lung infection. So you could say, okay, I want all the patients from this electronic patient data that have an autoimmune arthritis and a chronic lung disease. And then you can look for all the patients that had a TNF blocker and say, okay, which of these patients did develop a lung infection, who did not? So it can give you like, how do you say, an image of like how, if it's a risk or not to give it. So that's, so at first you want all the patients with an autoimmune arthritis. We already made subsets, so it would look like this. So based on Snowmed's IDs, you would extract all like diseases with an autoimmune process, pathological process that is found in the joints. So from that 1 million simulated data, you get like 60,000 patients left that have a form of autoimmune arthritis. So you can see rheumatoid arthritis or vasculitis, which is inflammation of blood vessels. So that's the first thing. Then you want, from these patients, you want every patient that has a chronic lung disease. And this is specified like every disease found in the lung with a chronic aspect, let's say. So now you have about 6,000 patients left who have both of these like aspects. And on this group you want to do a test. So you add test. And then you want every patient that has or has not used the specific type of medication, so the TNF blocker. And then you want to take a test on the chance of the possibility of developing a lung infection. Now, specifically, I choose bacterial lung infection because that has the highest risk for health. So you do the test. So then in summary, what we did is, of the million simulated data, we selected everyone with an autoimmune arthritis and a chronic lung disease. Then based on these data, it says 44% has used that kind of medicine. Of those, 5% developed a bacterial lung infection. Of the patients who did not take an anti-TNF blocker, only 2.1% developed a lung infection. So you could say that if you give this drug, this anti-TNF medication, the patient has 2.64 times more likely a chance of developing a lung infection. Now, of course, this is quite a simple example, and a doctor would weigh a lot of more factors, and it wouldn't make the decision. But it's a really handy tool to get live data and extract patient data and do tests on it. So yeah, that was what I wanted to show. Is it clear, or are there questions about this?
Your question is when will all labs be participating in semantic unification? More or less. For microbiology, it's clear. We have a timeline that says that in 2020 all medical microbiology labs will be participating. Whether they're already done remains to be seen. Some of them might take a little bit longer, but at least in 2020 we want to attract the remaining hospitals that are not participating, or the remaining labs, I should say. That's for the routine diagnostics. It's not for the genetic typing. That will also be carried out quickly, but I'm not sure what the timeline of that will be, because that's the pilot that we're still working on a little bit. And the typing will only be for the two things that we currently do typing on within the RIVM, so the MRSA and the CPE. So typing will take a little bit longer before all typing that's done within the AMR field is actually standardized and everyone will participate. So for AMR, it's fairly clear. So 2020, people should have been done the mapping, whether they're live in terms of providing their data to the RIVM. There could be some technical glitches there, but the mapping will have been done. So if within the context of this call, you can use that mapping for your project proposal. That should be possible. And in broader terms, for the Dutch labcode set, that remains to be seen how quickly that comes live. We now have, luckily, for 2 months, we have say the 80% of the most used clinical chemistry tests also coded. When and how the uptake will be, that remains to be seen, and that's something that's part of discussion with the ministry and with the Informatieberaadszorg, who has said, well, yes, we want to do this, but we don't have a timeline yet. Any other questions?
And how about, well, in the scope of One Health, how about veterinary labs and maybe even commercial labs who are in Germany doing diagnostics for the Dutch patients, is for human labs as well as for veterinary labs. So what about that?
Actually, I don't have an answer. Of course, you can still do the same mapping as Fakia explained, just using the codes there. The problem with veterinary labs is that Snomed is not fully equipped to deal with veterinary medicine I think.
It's true in that all the veterinary content was moved to a separate module. However, many of those lab tests, or at least the results, I mean, the microorganism isn't going to change. So that should, at that level, it might well work.
But in general, we are not including veterinary labs in the current project. So they will have to, and they can use the same methodology and the same tools that have been developed to actually do the mapping. And the mapping itself, it's not that big of a job. I mean, it seems quite overwhelming if you look at the 300,000 terms, but in practice, it's about, well, I think we budgeted about 10 man-days of work to do the whole mapping for ABR. So that's only 10 man-days. So if you have to do it, you can budget it and ask for funding to actually make it happen.
Well, the thing to remember is you don't need to map to the whole of the code set. You just need to map your data to the code set. That should probably be a subset.
In your simulated database, I mean, that opens a completely new science. But what is your basis? How do you collect such a database with all that basic information on different diseases, medication, different diagnostic procedures and diagnostic tests? How do you make such a database?
Well, this example, if you have an electronic patient file, which is based on Snomed code, you could use it. So it's not a separate database you build, but yeah, if you have a system or a file that works with Snomed CT, then you can do this. Yeah, doesn't really matter in which form. Right.
Are there already countries working with this Snomed system?
With this demo, it's not in practice yet, but there are countries who already implemented Snomed CT. I think, like in England, for example. Well, maybe you can tell more.
Yeah, so the UK uses Snomed, both the hospitals and the GPs. Also, the US, they have been using Snomed for a long while now, and there's a large company called Kaiser Permanente who does things that are even more impressive using Snomed, and various other research agencies. So yes, it's tried and tested. But I mean, you're right to ask, how do you collect this data? That's a lot of work, and I guess the most hopeful answer is that NICTIS, as a standards organization, we do try to further the use of Snomed. If people come to us asking what system should we use, we tend to point them in that direction because that's the most promising direction, the system that's going to give you the most detail, and which means you can reuse it in many ways.
I can add to that I think this is showing the power of interoperability in general, where the actual collection of the data does not have to take everything into account that you might ever want to do with it. You specify using standards that are existing or standards that you make in your community, you put that data into a standard form, and that will make it possible for people developing applications to use that data for incredibly different purposes. So the uncoupling of the data production from the data use is really what FAIR wants to accomplish.
Yeah, this is basically moving towards evidence-based medicine in a way, I guess. But is the intention that an art sitting in by a patient is going to sort of search this and make a decision, or is the intention that this is going to drive research projects? Because although the first idea is compelling, you can see sort of dangerous feedback loops in that.
Well, like I said, I think it can be, like, how do you say, a supportive tool for clinical decision support. So I think, like, it's a gray area, but... Sorry?
The genie might get out of the bottle.
Yeah.
Total stab in the dark, I'm not sure. It's a better situation. If the alternative is a total stab in the dark, I'm not sure that's really... Yes. It's not that we're recommending that people should abandon all protocols just to check their local hospital data to see which. Yes.
Mission creep with this.
I think the answer is we are not formulating such goals. We are simply handing you the means. We are making things possible, or trying to make these things possible. Then how medicine chooses to use that would be up to them.
So it's up to the researcher to use it. But can you make a connection with the call we are now having? Reuse data. So what? At which stage of preparing your project or performing your project will you start using Snomed, the labcode set?
Right, so we already established that this call does not involve the gathering of data. Otherwise, I would say the minute you gather it, right? But I will assume someone has a data set from somewhere or a set of data sets and they want to get working with them. I'd say almost the starting point is to look what kind of data is there and which bits are suitable to map to some kind of open standard. And if there are microorganisms in there, if there are lab tests in there, if there are outcomes in there, then look to these systems that we've mentioned. On the other hand, if you've got burger services numbers there, or well, no, you should map those all, sorry. If you've got locations there, you should use some other standard like geonames or whatever. But yes, so the connection with this call is that we would expect you to take a data set and add meaning to it by adding these metadata which refer to these particular terminology systems and thus achieve some semantic interoperability.